Hello, I'm David Kerr, Professor of Cancer Medicine at University of Oxford. I'd like to reflect just now a little on the concept of early tumour progression for patients who are being treated with chemotherapy, immunotherapy, many of whom are in clinical trials. This is something that I've had to think about over a long career as a cancer physician and researcher. And recently there's been a little more focus on this again, because there is starting to be a definition of a small group of patients who, on receiving immunotherapy treatment, seem to progress very rapidly. And what could be the mechanisms underpinning this observation. But stepping back from that particular subgroup, it is an interesting area. I've been looking recently in more detail at one of our clinical trials. It was a combination of our histone deacetylase inhibitor with an immune checkpoint inhibitor. The idea was that the HDAC inhibitor would reinstate immune reactivity in what were immunologically cold tumours. The hope was, actually with some evidence that this turned out to be the case, that the HDAC inhibitor would reinstate tumour antigen presentation, turning a cold tumour immunologically hot, and therefore making it a target for combination therapy with immune checkpoint inhibitors. It's a phase 2 trial. We published it fairly recently, 55 patients. And when I look back recently in real detail at the cohort of patients that we treated, these were patients with advanced colorectal cancer who had failed all conventional chemotherapy and who were a type called microsatellite stable. These patients are resistant to immune checkpoint treatment, completely so. Therefore, a very hard nut to crack in terms of trying to demonstrate returned immune reactivity. What I discovered was that about a third of the patients that were entered in the trial, these are late stage patients, untreated perhaps, life expectancy 3, 4, 5 months, that sort of order of it. It's a fragile patient group. But a third of patients only received one cycle of treatment before they progressed and died. So when we examined the results in the phase 2 trial, the average overall survival, it was the order of about 8 months, something like that. But in this group who only received one cycle of treatment, the average survival was 8 weeks. So quite a sort of very marked difference. And of course, if in advance we knew there was a group of patients who were going to do particularly badly in response to this combination treatment, or indeed any treatment, then you would seek to avoid treating them. The worst possible thing for a cancer patient is to have progressive disease and the side effects of an ineffective treatment. So if we could identify these patients before we treated them, then with a degree of sensitivity, we would exclude them from the trial and from that treatment. There'd be no point, because if they were going to progress to the point of death rapidly, then all we would be doing would be reducing the quality of their life with treatment, whether chemotherapy or immunotherapy. What is also interesting is that when I looked at, it's a small patient number, but looked at the characteristics of the patients who progressed rapidly, thinking about conventional factors. Is it poor performance status? Is it tumour burden? Is it multiple sites of disease? Is it age? The sorts of things that one would imagine could enter a multivariate prognostic model. None of these played out. Now, it was a very small sample size, and therefore it was me just poking around the database for my own interest. But there was no difference between, no obvious interest at all, looking at those conventional staging, recognized prognostic factors. We did a bit of, looking at RAS and RAF and some of the genetic tests, and do no difference there. A really small sample size, I'm going to keep saying that. But it did make me think that beyond the conventional things that we measure, there must be other that we must be more aware, or there must be better, more pharmacologically, biologically oriented tests that we could do to judge a patient's likelihood of response. So, for example, are there wider means of testing the immune system, how potentially active it may be, and so on. So a small thought to go beyond conventional prognostic factors in terms of patient selection for trials, and thinking better, perhaps more pharmacodynamically, are there tests that we could do that may allow us to select patients that would work better. As always, thanks for listening. For the time being just now, over and out. Thank you, Medscapers.